The broadcast is now starting. All attendees are in listen-only mode.
Hello and welcome to the August 2019 Pre-Hospital Care Research Forum Education Research Journal Club podcast. The Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. We believe that it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine pre-hospital emergency care. The PCRF partners with the National Association of EMS Educators to promote research literacy and advance the science of EMS educational research. Here with the PCRF Journal Club, we take a closer look at some of the latest research happening in medical education. I'm Megan Corey, and joining me in a few minutes will be David Page, and you all are out there, so we'd love to hear from you during this podcast. The study that we're going to be reviewing today is entitled Effects of Voice-Based Synthetic Assistant on Performance of Emergency Care Providers in Training. This was published in the International Journal of Artificial Intelligence and Education in 2018. So thank you all for joining us today. Let's begin, and we want to remind listeners that you can use the chat feature on your screen. You can type in questions and comments. We're going to bring those into the conversation as we go, and we welcome you, especially if you have some technological background or if you've used simulation equipment and you have some opinions about this and some input on this. Maybe you'd like to be unmuted and brought into the conversation. If you have something longer to state or you have a longer question, we would encourage you to just message our organizer and we'll have you unmuted and we'll bring you into the conversation. So let's begin. So an unacceptable number of deaths result from medical error, and we know that EMS providers might be more prone to errors on things like drug calculations and the application of time-sensitive interventions. This is due to the very nature of our work. So accuracy and intervention time are critical factors to improve through training, and that could improve patient outcomes. But are conventional methods in education sufficient and effective to optimize those outcomes? So these authors propose that the use of a voice-based synthetic assistant, we're talking about something like Siri and Alexa and Amazon Echo, could they enhance training and reduce the time to intervention and reduce the error rates? So they set out to look at this question, and I don't know if you've had a chance to read this article or look at this article, but they talk about augmenting. I think that's a really important piece of this. Nobody's talking about saying, you know, get rid of all these trainers and we'll just plant an Alexa here and have the Alexa guide the person through this complex, patient care situation. I think what they're proposing is how can we enhance these outcomes, things like reduction in medical errors, and then time to intervention. We saw a little bit of this, if you remember, and when Dave comes on, we'll bring this up again. We looked at a study about a year ago, I think, and it was out of Canada, and it was enhancing CPR quality of bystanders. And this was out of Ontario, I believe, if I'm not mistaken. It was the entire region used the same exact AED. It was one of the Zoll AEDs that actually provides feedback directly to the provider by voice, not just by visuals, but by voice. Might actually provide both too. I'm not completely familiar with which model it was offhand, but it provided immediate feedback during their actual performance of CPR on a real resuscitation, and they could pull those metrics off of the AEDs, and they looked at how the feedback improved the quality of CPR over time. So the opposite of what we thought, that most of the time we see CPR quality degrade over time. And in this study, I remember it was pretty compelling watching the immediate feedback improve the quality over time. So I immediately thought of that study when I pulled this one, and that's where it's not like I go combing through the International Journal of Artificial Intelligence and Education all the time. Ran through it, and it just reminded me of that that study. So I found it very intriguing. Now, this one, contrary to some of the other research we've looked at in this podcast, we've looked at things that are like big systematic reviews and things that have been applied in the clinical setting. This one is like going into Steve Jobs' garage, and when he was, in the 70s, when he was first developing the first Macintosh computer. This is a very lab-based, basic kind of pilot study. And the authors are pretty clear about that. So, you know, we have to temper our critique with knowing that the limitations are this is highly controlled and it's very lab-based, and of course a number of biases introduced as well, which they didn't mention in here. And I think we did invite an author. They weren't able to attend, but or they didn't respond actually, unfortunately. Usually we would try and get an author on. Would have loved to have had a conversation about how they control their biases in this, you know, in this study. So just because, you know, if you've ever been a technical advisor for someone who's on a startup of a, you know, a new technical device, then, you know that there's a lot of optimism and enthusiasm around a new device, but also introduces a source of bias. So in this one, they do actually propose that this could reduce training costs and enhance your monitoring mechanisms, because a trainer can't actually see everything, by actually using something that could detect and understand voice and be able to respond. So let's just walk through what they actually did and what they were measuring. And I'm going to I'm going to put this figure, it was figure 1 up on here, so you can see what exactly we're talking about. And this is kind of the techie architecture of a voice-based synthetic assistant. So I'm very new to this kind of thing, but if you kind of look at if you are seeing the slide, or if you're looking at the paper, you're looking at the first figure on the architecture of the voice-based synthetic assistant. What they're talking about is using the, you know, Amazon Echo was actually what was used. On the left side, the natural language processor, that's sort of the input. So that's the understanding of the person talking and what you've done, say as a provider. I've done this procedure, and this is what's going on. And then so all that whole left side is the input. The right side is the output. So this is kind of that middle row of, you know, data preprocessor and scenario calculator, and there's a whole group of algorithms in there that, you know, determine what to say next, and then put it into words, and then the speech synthesizer that comes back out. And then noticing one of the things that the authors do note, one of the huge limitations of these is the reliance on the internet. So we know that that's, you know, cloud-based. It's going to be really tough if you've got internet issues. So they do point that out. Actually, one of the strengths of this paper is the introduction and the background that they give on not just on medical error and the reasons for reducing error, and actually the promise of using technology to reduce error, but also just how the let me put up to table 1 so you can see, and if you look at table 1, this is a comparison of the voice-based synthetic assistant with other technologies in practice. They really go into, look at, this is what exists and this is what we do use. These are the strengths and these are the weaknesses. So what synthetic assistant, or I'm sorry, synthetic, the voice-based synthetic assistant, what this has a tendency to do is use the core existing technologies like speech recognition and dialogue management, text-to-speech synthesis. It can, you know, data mine and analyze and, you know, pull out information and then personalize to perform certain tasks. So that's one of the strengths of it. But if you look here in this comparison of existing technologies, you'll see that they compare this. So you have the medic training technology, voice-based synthetic assistant, versus Laerdal robot mannequins, versus a combat medic virtual training, which is gaming basically, versus custom pedagogy, and these are avatars. So this is like the personalized avatar. I would imagine, and that this is like the heart codes, where you have your advanced computer generated avatar that can monitor a process and then respond. Now, each one is going to have its limitations, and of course the strength of actually having the mannequins themselves is that you have some sensory input. Now, another study we looked at earlier, the PCRF education research review was one out of Australia, and that was a augmented reality. So augmented reality will combine sometimes the virtual reality visuals and kind of gaming technology with the haptic simulator so that you actually get a physical feedback. And this one that I had seen was it was really designed to reach rural students in Australia, and the student was sent a set of 3D printed laryngoscope blade and handle, and they used their iPhone to pop into a headset and used a program so they could see an actual head, and when they reached in, they reached forward with the laryngoscope, they could elevate, they could position the head and elevate the mandible. And there was some degree of feedback on the laryngoscope, and that's what they were working on. So you could actually get the sense, not just use the technique physically and walk through the muscle memory, but actually get the feedback. So that was when they compared these, they said that, giving that realistic, the ability to actually touch something really gives you the strength of having the physical mannequin. So the voice-based synthetic assistant, though, what it's really designed to do is a little bit more. They're getting more and more advanced, right? So it's artificial intelligence. It has access to all the resources. It can grab the resources. It's not just a basic algorithm, and then it can feed back. And they actually have a link to a YouTube video that I watched that's, I will warn you, it's not very impressive, but it shows you the very beginning of when they were starting to train using Amazon Echo. It was one of the simulations. And the link is actually in the article. I would encourage you to kind of check it out. And this is exactly what they're looking at. This figure 2, you have the cloud itself. It's a cloud-based synthetic assistant model. Amazon Echo is the one they used. And then you see on the right, you've got the emergency care provider, which they're calling an ECP, who is a military combat medic, with a very basic simulation, a very rote skill, which is the massive hemorrhage protocol and tourniquet application. So they decided to use this model, this massive hemorrhage model, use the Amazon Echo, using the cloud-based kind of simulation or synthetic assistant, and then run a control and an experimental group, which we'll go through in a second, and compare the standard educational procedure for teaching about massive hemorrhage and tourniquet application versus enhancing that training, that very same training, with the Amazon Echo and something that could interact with the provider. And the outcomes they were going to look at were the ones of interest that were, mentioned in the introduction, which are, does it affect the time to the task, the time to the critical intervention, and does it reduce the error rate? And so you have to define those two things. What is time to intervention and what is the error rate? So they came up with those. They have a pretty detailed explanation of how they went about this. So let me just go through their subjects. And again, if you have any comments about any of this, just go ahead and type into the comment field or questions, or you can be unmuted and we can have a chat. I want to go through the subjects and the selection, because I think that's a really critical piece. And when Dave comes on, we're going to talk about this, because there's some issues here that I think are really important to get to. So the subjects that they wanted to study, or that they chose to study, were 36 participants, University of Toledo, and then local high school graduates in the area. Their median age was 22. The range was 19 to 36 years old. And there were 14 women among those 36 participants. 16 of the participants had bachelor's degrees, 2 master's, and 17 were high school graduates. So it's important to discuss the demographics, of course, because familiarity with the technology and anything that will influence the outcome student is affected. You want to look at all of that and just kind of get a kind of an overview of who we're talking about here. Incidentally, they do mention that a lot of this technology has been looked at in the military combat medics in particular. So the selection, though, I thought was really interesting. The selection was based on English accent proficiency. So automatically we can see that this has very limited application right now. But again, they're looking at something very specific in the lab. So English accent proficiency was based upon the ability to kind of be understood by the the synthetic assistant, so to be understood by the Amazon Echo. And we've all seen funny videos about, the misunderstandings between, Siri and Amazon Echo and Alexa. And, I don't know if you've seen the one, but that was 2001: A Space Odyssey, a little meme on that was quite entertaining. But that's exactly what you can anticipate, happening in EMS. So that was an interesting thing. What they did was they had them read 4 sentences. So in order to recruit participants, they kind of recruited from, like we said, the local area, from the college and the high school graduates, but they also had them read 4 sentences, and they went by understandable, whether it was understandable to the synthetic assistant. And they did that because they wanted to really get to the actual outcome of use, which is time to intervention and error rates. So time to intervention might be affected if Siri or Amazon Echo can't be understood. So that's the reasoning for going with that English accent proficiency. So their control group there were 17 in the control, 19 in the experimental group, so nice and even. And the control group was trained using a standard methodology with an instructor and an instruction sheet, and then they would perform. So it was a training session and then a performance session without prompting. So pretty traditional. Here's your training and here's your performance without prompting. And then they would measure their metrics from there, and we'll go through what those metrics were. And then the experimental group, they were trained using the standard procedure, but enhanced by the Amazon Echo. So, and again, you can see that in the YouTube link that's in the article. And then they performed. So it was the same thing, that the intervention was going to be just adding the Amazon Echo that could interact and with the person that was performing. So as the person, the trainee, would make statements just like they would out of the skill sheet, the Amazon Echo would respond and actually prompt them. And you can see in the paper, they actually have an example. What you're seeing right now, if you can see the slide, is the image of the model that they used. So this wasn't a full lifelike simulation. This was a very rote, simulation of really a skill of the massive hemorrhage protocol, application of a tourniquet to someone with uncontrolled bleeding. They used just not even really a realistic, mannequin, just a piece of a pseudo leg, and there was no blood and no mess, and there was no visual indicator. It was all voice. So this is highly, simplistic, and is not designed to mimic anything. It's really designed to see if this would, if you could actually see any kind of budge in a couple of these metrics. So that's exactly what they did, what you're seeing here. And so those were the groups. And then the outcomes they wanted to use, and again, they used the massive hemorrhage protocol. Oh, incidentally, so then the control versus the experiment, they repeated that ×3. So this was training using a sheet, then performing, that's the control group, and then you do that 3 times. So you have a training and a performance, a training and a performance, a training and a performance. So I can't offhand remember what the time element was in between. So there must have been some kind of a time in between. Then the experimental group was training with the Amazon Echo and then performing and repeating that 3 times. So that was the experimental group. And again, I don't recall what spread was in between. These were incidentally novices. They made a very clear point to make sure they did not have any medical training whatsoever, and that they didn't talk to each other to give feedback to one another to affect the outcomes. So the outcomes were the time to treat, and they determined that the critical period for a time to treat is 65 to 95 seconds, with an ideal of 40 seconds. And then they wanted to look at numbers of errors. And now numbers of errors, and keep in mind, this is the critical, one of the objectives of this is really to study the utility of this for training these novice learners. So I think that's really important to remember as you're going through this. Okay, so the primary goal is real-time monitoring, error detection. And so how are we going to define what error detection is in a massive hemorrhage protocol using a leg and tourniquets? So what this went by really was communication. It was really more of an evaluation of their communication. So they defined these things: true positive, true negative, and false positive. And essentially, if a scripted speech command is performed accurately, so if Alexa tells you place the tourniquet, it's performed accurately. And the if you have, and actually that's not true. It's actually if your scripted speech command is performed accurately and the virtual-based synthetic assistant executes it accurately, if you need the next step performed accurately, then it's a true positive. If the scripted speech command is performed accurately, but the voice-based synthetic assistant rejects it, then it's a false negative. Now you'll notice in those videos that Alexa says, I think it's Alexa, says okay quite a bit, okay, and there's another scripted line that she says over and over again. It's a little annoying. So, and you can see that the trainee gets a little annoyed as well. So there's definitely a basic level kind of experiment here. Now, when it comes to the if the scripted speech command is performed inaccurately and the voice-based synthetic assistant rejects it, then it's a true negative. And finally, if the scripted speech command is performed inaccurately, but the voice-based synthetic assistant accepts the step based on it, then it's a false positive. So the outcomes you can see here in the training. So this was training session 1, 2, and 3. And essentially what you're looking at is the true positive and true negative. This is a correct operation of the voice-based synthetic assistant. The false negative, false positive would be the error in the voice-based synthetic assistant. So this is just testing whether or not it even works, in terms of communication. And you can see that the correct operation outnumbered the errors. So as they were going through the training. Now, what the authors then did was they wanted to look at the metric of what's called a P-score. This P-score is a performance score that they had a calculation for. And, I don't have a statistician here with me to explain any kind of issue with this. So we're going to look at, I know that you're looking at this plot here, 2 plots here. One is the upper one is the P-score, which is the author's, the researcher's determination of the performance, the accuracy basically of the application of the treatment. And what you're seeing is training session 1 followed by test session 1, training session 2 followed by test, training session 3 followed by test. And in the orange is control, and then in the green is the experimental group. And you can see the range of P-scores in each one. You really like to see those a little tighter, and as you go, you can see them sort of tighten up. You can see a little bit of a difference in the calculation that they had for the P-score and the metrics that they set. Noted that there was a statistically insignificant difference for the control group, or increase in performance for the control group, but along the experimental group, looking along the green, they had significantly improved from test 1 to test 2 and from test 2 to test 3. So the authors figure that the hypothesis of this performance enhancement in training, as measured by this P-score, when compared to conventional training, the VBSA group, was that their hypothesis was validated. Then they noticed that repetitive training also seems to be more effective, which is that a surprise to anyone out there? I don't think so. And you saw the successive tests, 1, 2, and 3, and a little bit more so in the voice-based synthetic assistant. Now, the next one is time. So it's time to complete a given task for the control group versus the VBSA group. And there was no statistical significant loss in execution time between the control and experimental group in any test scenarios. And actually the authors say that the training time of the experimental group being longer than the time taken by the control group, that discrepancy can probably be attributed to limited vocabulary, but they also say it's really important because the execution time between control and experimental group not being significantly different might show that the effective cognitive load on the individuals due to this added assistant was minimal. So we've talked about cognitive load here. Is there an additional cognitive load by having this little thing that's talking to you over on the side? So the authors concluded, based upon these results, that the VBSA doesn't have any adverse effects on your task, on the individuals, the subject's task execution, speed, the stress factors, the cognitive load. But, of course, they need more samples, more treatment test cases, more nuanced effects of this. So, and let's see, these are really their primary results, but then what they wanted to do too was to look at errors. And I think errors is a big deal. How many times are you, kind of making certain errors within the life of this technique? And this is a pretty, basic simulation, right? It's massive hemorrhage. This isn't a complex medical case where you've got to perform a differential diagnosis. It's not something where you're calculating a drug dosage and the patient is a pediatric patient and there's everybody around you. This is a very controlled situation. So, we know we have to take these results for what they are. So table 3 then shows the control errors, the control group errors versus the experimental group errors. And they had concluded that the number of reporting errors and if you look just across the table, what you're seeing is implementation errors, and that's an IMP, versus the reporting errors. And again, that's this has to do with implementing treatment and communicating with the device. So you can see training 1, test 1, training 2, test 2. You can see each of the 3 experiments across. You can see the control group or each of the test sessions, and then the control group versus the experimental group. Implementation errors versus reporting errors. Implementation errors, you scan across there, you don't see a huge difference. The authors really dive on testing session 3 and say, look at how much lower it got here, but that was one data point, and really the trend across, I don't know, it doesn't seem too great, but the reporting errors is where we're seeing a difference. So across, especially as you go through testing and training sessions, repetitive training sessions. So I think we have Dave on. Dave, are you here?
Yes, Dave, absolutely. I just had to unmute myself so that
sorry.
You can hear me. Sorry.
I'm going back to a few slides before so we can show sort of this setup. So what do you think about all of this? What was your impression when you first looked at this?
Hey, Alexa, am I making a mistake? Hey, Alexa, I just gave, 3 milligrams of, Zofran, and I should have given 4. I love it. I thought the creativity and design using a tool that anybody can use. So for budding researchers out there that say, well, could you actually do this? I'm anxious to see if anybody who is listening to this might think, oh, our paramedic students could do something similar. And obviously, you know, the depth of the analysis is interesting. I thought that the you know, like many kind of headlines here about, you know, does this improve patient care? I thought, you know, in the end, the instructor's still the one that's actually going to say, okay, the thing got put on accurately. There's no, you know, the Alexa doesn't know if the tourniquet is on, you know, or not properly.
Exactly.
But so I think there's some limitations that make this kind of more a time-based piece, like how quickly could I do it even if I'm doing it wrong? And I thought, you know, in terms of its utility to what we do, I thought, you know, we could explore this a little bit more deeply if compression fraction is a factor in the patient outcome, and we really want paramedic students and MP students to do this well. Then perhaps the concept that Alexa can time our compressions and go, okay, these are you know, properly done, or can keep track of some of the things that are key components. If in the simulation one of the key components is, you know, we initiated CPR within a certain amount of time, or I thought that has some utility. But I would stop short of saying that they figured this out. I think this is sort of very, very experimental and very exciting, because
very exciting.
I do think that, you know, when you talk about computer inputs and whether or not we should be typing information in, or the somehow the mannequin should be so advanced, which is great that we have advanced mannequins like that, but not everybody can afford them. So the mannequin keeping track of things was kind of one version of this, but I do think this brings an entire new concept around how we capture performance. And I am intrigued. It was very difficult to get this article. You know, normally it's very easy for me. Obviously, I'm lucky. UCLA has a big library, and they can usually get something. But interlibrary loan took a long time to get this deep in an artificial intelligence journal, and it wasn't so intuitive for me to be able to just pick that up. So in terms of the artificial intelligence component of this, could there be, you know, could Alexa learn what's important about this simulation and be listening for, in this simulation, we really need to give, you know, 0.3 milligrams of epinephrine for anaphylaxis, or in this simulation, the EMT needs to make sure to ask for allergies, and then kind of check these things off in a.
That's what I was thinking. I was thinking that, you know, could there's so many talking points here. There's so many things to discuss, and I do think it was ironic. You know, talk about cybersecurity. I could not get this article. It took me like several times, but I'm really glad we're looking at it, because it is very exciting, and as limited as it is, it's still very exciting. But I was thinking exactly what you were thinking, which is, you know, can you be, you know, you're in the back of an ambulance and you're dictating basically what you're doing. You know, I'm getting ready to give 3, like the med check, right? I'm getting ready to give 3 milligrams of, and have them say, yes, I confirm that. Make sure that you've done this, and have you know, don't forget to do that. And oh, by the way, I listened to your abdominal pain assessment, and did you ask for allergies? Did you ask for pregnancy? Did you ask for, you know, and having them prompt certain things. That would be a very interesting training model, but also even a practice model. Before you came on, I had mentioned that we looked at that Canadian study, if you remember, the one about the quality of CPR of bystanders, and they used the interactive, I think it was the Zoll AED that was, you know, the high level one that actually doesn't just provide you, little visuals, but also voice feedback, compress deeper, a little bit faster, that kind of thing. And they saw those metrics go improve drastically over the life of a single, resuscitation, and they saw an improvement in patient outcome. So that's what it completely, I thought of that when I read this, even though it's a stretch.
Anybody who's boarded an airplane recently and sat there waiting for everybody else to finish boarding has heard the pilots in the cockpit, play each one of the sounds that the computer in the cockpit is doing. Pull up now, pull up now, and so I do think that voice prompting works both ways. If the artificial intelligence world were really to want to improve patient safety, we could see not only are we listening as a tool to document, but a much more robust way to have insertion, have actual, checklist style. You're treating abdominal pain. Have you asked about this? Mm-hmm. I think in terms of exploring all of the tools that gives you, I can't imagine that translation, especially with patients that speak a different language.
Yes.
And so currently, simultaneously, you can be speaking at a Google translator, and it's piping out the words in a different language. And so it seems like these types of tools could be extremely useful to both EMS education and actual care. So I'm
there is
really
that
excited
piece,
to see
though. Yeah, there is that equity piece, though, too. Like we keep talking about this, about making sure that we're accounting for the multiple cultures, and we talk about cultural humility, we talk about all these things. And then I had to sort of laugh to myself when I saw, okay, the way that I recruited them is by, can they speak the Queen's English, But I understand that they were trying to see if the, if the communication aspect of it would work, so they didn't have to take that variable out of the equation. But, it also dawned on me that it would be great to have Jaime Flores on here. I watch his Twitter or whatever the other one is that I'm following.
Instagram,
one of his social media feeds all the time, and he's always got something very cool, in terms of simulation going. And I'd really love to get his take on it, on what he thinks of something like this, or if he's ever used something like this, or it would just be very cool to have him on.
I love it, and I think it's a good time to reiterate what you've already said, which is we have experts that are already tuned in, listening to us just ramble on, and actually have quite a bit to contribute. So if you have a question or a comment and want to be either unmuted or just type it out, there are obviously folks like Greg Fries and Leah Tilden. I'm calling them out because I can see their names, that are experts at teaching and how the world of electronics begins to blend with the world of reality. That, like Dr. Flores, you'd think, okay, well, how could you make this work? And I'm super curious because I'm not an Alexa user. I'm a Hey Siri kind of a user, and Siri has some serious limitations. And
Yes.
I think, when I think of Alexa sitting in my house, listening to everything I'm saying, I think maybe you name it, the Russian, Chinese, or whatever government you want to think of, is listening to everything that is happening in my household. So we haven't quite embraced this, but in a classroom, I'd find it fascinating to see if Alexa can interface, if in fact she, the artificial intelligence element can actually, again, not just be a data input, but also turn on or turn off certain aspects of what's going on, and
and detect detect is really important, because there's no way, and this really bothers me. I'm a big believer in simulation-based education, but it's very hard if you have a class, let's say you have a class of, and let's just pick a regular number, 20, 25 students, and you've got to rotate them through some simulations, and you've got a well-oiled machine, and you're able to do this, and maybe you're able to even videotape and look at it later. If you've ever done this, which I've done, it's very hard to monitor a student who has been making a persistent error, even in just the angle of insertion of an IV in the mannequin during a simulation. So you can do that, and we can say, okay, but you should check them off on rote scenario or rote mannequin first. Okay, say you do that, but we know those skills can degrade. They can get input from other people that's incorrect. They can, those skills can suffer, and sometimes it really bothers me. Every class I've noticed that, well into their education, almost ready to graduate, and they're doing something. I'm like, where did you learn to do that? Well, I tried it this way, but I always thought we were supposed to do it that way. And you think, wow, how did we miss that? Well, because we can't watch every single detail of every single scenario to make sure the integrity of the skill is maintained, to make sure that, we can as educators run 30 scenarios in whatever, a couple of weeks. But think about how many that means to each individual student. It really isn't that many. And they're not always leading, and they're not always performing the same skill over and over again, and they're not always getting the exact feedback. And so the idea that this could augment and enhance, and it could detect, real time, the possibilities are just tremendous for reducing error and increasing accuracy.
Yeah, I love that you brought up the med check as a good example of this. The virtual partner, as Leah Tilden has so aptly put a note here in our chat, the virtual partner to double check the medication and being able to repeat back is a concept that we in aviation and in the military, people are very used to. You get a direction to do something, you repeat it. This could be a tool that could begin to indoctrinate, even without an instructor present in the room, as you said, a student into exactly what did you say, and then get the artificial intelligence component to be able to confirm it's been done. Oftentimes we think we said something, and as you said, you can have whether it's an exam or an actual patient interaction, your concept of did that get answered? Did you asked it, but maybe you got distracted when somebody replied, and there's this, we have this, there's a fail-safe in the process.
I think I just thought of a great cool study. If you can get your virtual peer evaluator reliable, they can view and detect and critique. I'd love to compare a virtual peer evaluator versus your peer evaluator, human peer evaluator versus your human instructor, and inter-rater reliability and accuracy of detecting errors in student performance in a simulation. Every student too, not just the team leader, right? So not just the team leader, you got, 4 or 5 people in this team that are running, if they're running complex simulation, maybe there's 2. It's easier to watch 2 people than it is to watch, 5 people. And you can videotape all you want, but I've videotaped, and unless you've, number one, got the time to sit and pick apart each person in that skill, and the skill that they're running, and what they're doing, and all their safety metrics and all of those things, it would be, I think that's the virtual peer evaluator.
Yeah, and not that I'm a fan of, actually far from it, I'm a big critic of just rote memorization of a skill sheet and just spitting it out. But but novice learners who are kind of in that mode of having to learn each step, really do need that definition of this comes before that, and in order for this to work, I need this information. And so much of the skill evaluation process has been a recitation. That I do think that it is true. You know, the virtual partner or virtual examiner could be that. I think it's funny. We did call Greg Fries out, and so he's aptly calling me out again. But that's good. And he, you know, he's mentioning the Sedgwick County medication cross-check that you mentioned, and how important that would be. I think you have to, as Greg points out, you have to activate Alexa. Which is a little bit of a, you know, she's not listening in the background all the time, except for she is listening for you to say Alexa. But then she's, you know, the AI can then activate something or read back a protocol like, you know, hey Alexa, med check, you know, yeah, okay Dave, what medication do you want to give? And have enough savvy to say, you know, you wanted to give 30 milligrams of morphine, like, that's outside of the safety parameter. But, you know, I do think that.
Or just walking through the med check, you know, any allergies, any, you know, whatever, you're just walking through. What's the weight of the patient? Checking the protocols, like Greg said, you know, checking against the protocols. Yeah.
We had a winner of the PCRF research forum from Come to Expo, an international presenter from Denmark, and he presented a machine learning algorithm that Greg found here on PubMed. It was fantastic because the machine learning algorithm and it was listening to the caller as they dialed 911 and could identify that, in fact, the patient was in cardiac arrest with more speed and accuracy than the dispatcher themselves. So there are some useful tools inside, you know, kind of an aggregate information system that would say, when this is happening, there's a statistically high likelihood that this is actually a cardiac arrest. And whether it's words spoken or the types of complaints matched with the types of answers, these were very astutely applied to a dispatcher 911 call. If we can do that, then like what we're hearing from this particular study in terms of, you know, a military simulation of bleeding control, we could perhaps achieve that kind of a feedback system.
The one thing about voice activated things too is I always worry about ancillary noise and noise levels, and you know, that's one of the things that you're always thinking about, just trying to apply it to a next level thing. So, and then like we were saying, and accents and the ability to understand. So that obviously the technology's got to go somewhere, and that's why I say it's more than just what you're saying; it's what you're doing, and that's why it's the more that things can detect, just like the feedback devices now in CPR. I think I think we're really going to start. The more they're enhanced, the more they're really utilized in a systematic way. You'll start to see big changes. Because of the direct feedback, I think it improves the comfort level as well. And I can't remember if that study discussed it, but it improves the comfort level of bystanders. And it may be that bystanders because remember, these were novices, these were not medical people. So bystanders and novices may be the ones who benefit the most, because it provides them some degree of confidence and comfort that somebody else is telling them what to do and how to do it.
I really love that the study calibrated the voices of the two participants prior to beginning, because it was a question for me, you know, if it's just kind of, it's not very realistic to think that Alexa will have never heard just the sound of your voice, you know, when you're actually using this simulation. Obviously, if you're, I guess if you walked in cold, but the idea, if it translates into the field, is that these words and your pronunciation of the word or your handling of the grammar is something that it can it already has algorithms to say, okay, that word means this sound means this.
Yeah.
And I don't know how many times I had to autocorrect when it changed my location of, into my phone. I'm texting someone and I'm saying, oh yeah, the PHTLS class is whatever. And you look down and it's like translated some bizarre thing that's not even real. But more and more, I think, and I don't know if this happened to you, but mine is actually now hearing PHTLS and it knows to type PHTLS, even though it probably doesn't even know what that word means. Because I've auto-corrected it enough, and it knows, oh, when the sound is this is what's being understood. That I think these things begin to improve over time, and that's artificial intelligence at its best.
Yeah, I don't know. I mentioned it earlier, but there's a great little video on. I think it's from 2001: A Space Odyssey, where he's saying, "Open the pod bay doors, Hal," and Alexa can't seem to understand him, and he keeps saying it over and over again. It's this one scene from 2001. He ends up playing a song from the Doors. It's actually quite funny, but it reminds me of exactly what you're talking about, and that misunderstanding or not understanding can be more frustrating. It actually happens in the video that they posted also in the article, so you can see the frustration of the person who's learning, trying to repeat what he said, to get it to understand.
Love it.
Yeah. So one of the things, again, it's sort of the application of where can it replace but not enhance. And one of the things that I thought of too was, I can't remember what it's called, and maybe somebody out there can just remind me in the chat area. But there's a Google Talk that they had some very splashy headlines and audio of a voice that can call and make a restaurant reservation, or it's taking your restaurant reservation. That's what it is. You call and say hi, and it sounds just like a human. Oh, hi there, and I even use ums and uhs and how can I help you? And then you say, oh, I wanted to make a reservation. Okay, I see you want to make a reservation, and how many people?
Yeah.
And you can't tell the difference between a person, and I know it's a very simple thing. We all say the same things. Usually we call a restaurant, we say, I'd like to make a reservation for 2. Do you have anything open on a Tuesday? It's, and you can even use little nuances, and it's programmed to actually respond. And it's very creepy. It sounds exactly like a person, and it responds to all the little nuances, because there's probably very few words that we say outside of the things you would say when you call. Whoever built the algorithm thought of everything from, do you have an extra room or high chairs or whatever, to because they tried several little iterations on it, and it was still able to respond. So that kind of technology, it's there somewhere.
It is. And when I call Delta, there's a voice that doesn't sound anymore like, hello, thanks for calling.
Yeah.
It's more, it's a much more, what can I help you with, David? And you're going, okay, all right. I know you had somebody record every name in the book or trying to pronounce that.
Yes.
I will say on the skeptic side of me, that the more we try to make mannequins like humans and machines, like Alexa, be more human, the more I feel like we lose a little bit of our humanity. And I think that this business is all about humans. It's about us, hearing the inflection of the voice when somebody says, you say, do you have chest pain? They go, no. And that's a yes, but it's, maybe it's chest pressure. Yeah. And that I think that it's the AI is a long ways away from being able to, and maybe never will get to the point where it can detect some of the things that a human can detect and see. And I did think this was a major limitation in this one particular study about the headline, improving patient care. Really, I don't know if they can support that conclusion if what it's all based on is how quickly could you put the tourniquet on. Because I really have seen many tourniquets placed on incorrectly in the wrong spot, or tightened incorrectly, and that in fact the human is the one who actually has to say that's incorrect. And I'm happy to have a secretary, Alexa secretary, keeping track of this, because certainly having to type it in afterwards in an electronic documentation format is horrible. But I want to be careful not to take us to the extreme, which is that we routinely are looking at situations that that don't fit the pattern. They don't fit the normal, and people tend to forget this is the practice of medicine. And scientifically, yes, we'll try and find the evidence, but practically speaking, there's still, we shouldn't lose our humanity.
Yeah, and they might be able to mimic empathy, but it's not there. So that's another aspect.
How would you feel? You're depressed, and instead of talking to a human, you're going to call a support line, and a computer is going to let you know. And maybe there's and I'm sure actually there's science around systems that support the other humans, and you feel you call into a line and you're getting feedback about something, so you feel better. But if I'm elderly, isolated, it's one thing to be able to have Alexa turn on my lights and make sure that my maybe even that my dog is fed. But there's not an Alexa that can go pet the dog and make sure that it didn't have diarrhea.
Yeah, exactly, or feel the warmth of a human touch. That's very true. But it does raise too, what are the things that it can do better than we can in terms of being more attentive to things that will affect that are in the line of prevention. Reminders about medications, safety aspects, just things that could help prevent certain things.
I like Greg's comment here about in the Denmark study on sudden cardiac arrest, the computer did detect a nuance in inflection, and I think that's really important to point out, that it's actually better at doing that, and better at not having some of our biases, the phone call that we think the person is maybe a little too panicky and over exaggerating, and we bring into it a bit of our own experience to say, that's maybe good or bad, and then we have confirmation bias and all the things that lead to error. So I do love that the machine is picking up on those subtleties, and I think that's a great comment.
Yeah, that's great. We have only a minute left, so thanks. I just want to thank everyone for joining us. Do you have any final comments about this, Dave?
Just that I think EMS providers at all levels, including our listeners and educators, should use this study to begin replicating or adapting it to their classrooms. And that we absolutely should find ways to integrate this, even to do further small experiments about how it might be useful to do data entry, or to make sure that a student goes through the checklist. And let's play with this. So this is what research is all about, and I think it improves patient care, and can't wait to see the next one.
That's a great point, that, again, this is a good one to bring to your class, have a nice discussion, a great journal club of your own, and bring up some great ideas from them. And guess what? It's not that big of a study either. And with a few folks together, you could replicate something like this quite easily. Congratulations to the authors on publishing, and congratulations to all of the authors last month at NEMC, at the NEMC conference, which was a big success for our EMS researchers, and we can't wait to see what's on the horizon for more. So thanks for joining us next month. Of course, we're going to join you again with the clinical podcast on Monday, September 9th. And then on Friday, September 27th, we'll be back here with an education research podcast. We'll have an article coming up pretty shortly here. And those are both at 10 a.m. Pacific, noon Central. Thanks again for joining us, and we'll see you next time.